Coming to the 11th one. A 55-year-old male with a history of chronic alcoholism. Use prevents with a history of chronic alcohol use presents with jaundice, fatigue, and abdominal pains. And laboratory test has shown that there is an elevated liver enzymes, bilirubin, and also elongate or prolonged prothrombin time. A liver biopsy is performed to access the extent of liver damage, and the histological section is shown below. So, liver histological section was given in this way. Based upon the histological findings, patient is risk for what structure is. So here, what are the risk factors for the patient is chronic alcohol. So whenever the chronic alcoholism is there, then the initial damage is for the liver. So liver might be the problem. And also the diagnostic test shows that there is a elevated liver enzymes, bilirubin, and also prolonged prothrombin time with the same symptoms are also associated with it. That is jaundice, fatigue, and abdominal pain. So what is the organ that is affected is liver. Now what happens in that liver? Let's discuss about that part and what will be the risk factor. So what's the histological image that was given for the thing is, he has a chronic alcoholic patient and he has elevated liver enzymes and also jaundice symptoms also there. So everything is directing towards one organ, that is liver, and that liver histological section was given. This is the histological section that was given in the image based question. So in this, before going into this image, first we have to understand what are all the changes that occurs in case of chronic alcoholism. Is first, if there is a chronic alcoholism if present, there will be the vesicles that will be appears within that of the cells of liver, that is called as hepatocytes. So fat steatosis will be present. Steatosis, the initial stages is the steatosis is present, and it may be microvesicular, that means the small vesicles are present, or it may be macrovesicular, that means a single large vacuole will be vesicle will be present. That's the initial part where in case of chronic alcoholism will be present. First stage is steatosis. This steatosis is followed by inflammation of hepatocytes or portal triads. So either the hepatocytes will get the inflamed or the portal triads will get inflamed. That inflammation will lead to formation of fibrosis. So that huge fibrosis, if it is seen in the entire liver, that fibrosis part will encircling a part of the liver that leads, that's called as nodule. Nodule like appearance of hepatocytes. So these two are the features that can be seen in case of cirrhosis of the liver. So chronic alcoholism, the initial part is the changes is called as steatosis, and it is a small vesicles is called as microvesicular, and if it is large vesicles then it is called as macrovesicular. After that, there is a infiltration of these lymphocytes, neutrophils, all those that leads to the inflammation. So wherever is the inflammation, it will be followed by fibrosis, and that fibrosis will surround the group of hepatocytes, and that group of hepatocytes is appears just like a nodule. So this is what the pathway that can be occurs in case of cirrhosis, and this cirrhosis part, if continuously present, will leads to hepatocellular carcinoma. Risk for carcinoma is present. Okay, so let's go back to the image that was given. You can see here within this image, these are all the fibrosis that was already done within the liver, because whatever the organ that we have a conclusion that this is the organ of liver. So within this liver there is a continuous fibrosis here. This is also the fibrosis. The entire is a fibrosis. So majority part is getting fibrosed. Because of the presence of this more fibrosis, it is enclosing a group of hepatocytes. This entire whatever is I am highlighting, this is fibrosis. Now this fibrosis is enclosing all these hepatocytes in a group, right? So this is considered as one nodule. So a fibrosis with a nodular appearance, as it was shown, thick bands of mature fibrous tissue is present. This is a mature fibrous tissue, and this is another nodule of hepatocytes. This is another nodule of hepatocytes, which is surrounded by this fibrous tissue. So wherever is the fibrous tissue is surrounding, the island of these hepatocytes is called as a nodule. So this nodular pattern and the fibrosis, if it is seen, then what is that condition is called as cirrhosis. So whenever the cirrhosis is present, then the risk for hepatocellular carcinoma. So if you going back to the question, so in the question, it was a chronic alcoholic, liver enzymes is elevated, symptoms are also supporting that of the liver damage. So the section, histological section is shown is liver. And within the liver, we had seen a fibrosis and a nodular arrangement of hepatocytes. This is one nodule, this is another nodule, this is another nodule. So these nodules are surrounded by fibrosis that leads to a, that condition is called as cirrhosis. And what is the question is, based upon the histological findings, patient is risk for. So here, what is the part that was given in histological section is cirrhosis. So whenever the cirrhosis is present, it's an increased risk for hepatocellular carcinoma. So that is option number A. So answer for 11th question is A. As the given image is of cirrhosis, so the patient is risk for hepatocellular carcinoma. And why it is cirrhosis in the given image? Because it's a chronic alcoholic patient. That's about the 11th question. Coming to 12th question. A patient, a 45-year-old man, has represented a sudden onset of right side facial paralysis. Remember, right side facial paralysis. And also, there is a loss of taste of the anterior two-thirds of the tongue and also hyperacusis. Hyperacusis means even the small sounds will listen as a large sounds. That's called as, simply can say increased sensitivity of the sound. A detailed neurological examination suggests that the lesion is affecting the facial nerve. So what is the nerve that was affected also given? That is facial nerve. And an MRI is performed and the image shown in the lesion compressing the structure as it exits the cranial cavity. Which foramen is likely involved to observe these symptoms? See, facial nerve is actually comes out between the styloid process and the mastoid process. And the foramen between these two is called as stylomastoid foramen. As the foramen is present between styloid and mastoid, so it's called as stylomastoid foramen. So obviously there will be a stylomastoid foramen. So let's see, but what are all, why these features are present also we have to discuss. So going for the workbook section. Let's imagine this is a facial nerve, outline skeletal part. This is the midbrain, this is the pons, and this is the medulla. And just in front of the brainstem, we have internal acoustic meatus, IAM. Internal acoustic meatus. And below that internal acoustic meatus, we have middle ear. Middle ear. And behind that middle ear, we have stylomastoid foramen. Just in front and below the stylomastoid foramen, we have a gland called as parotid gland. Let's imagine this is the anterior two-thirds of the tongue. And this is pterygopalatine fossa. This is the outline skeleton of how the facial nerve comes out. So facial nerve usually starts at the level of the pons. This is called as the seventh nucleus, but it winds around the sixth nucleus and comes out. Let's imagine this is sixth nucleus. So it winds around the sixth nucleus to form a colliculus called as facial colliculus on the posterior pons, or we can say the floor of fourth ventricle. So it winds around the sixth nucleus and comes out and then enters the internal acoustic meatus. Then it suddenly descends and goes along the medial wall of the middle ear and then the posterior wall of the middle ear to exits through stylomastoid foramen. Once it comes out of the stylomastoid foramen, it pierces the parotid and divides into 5 terminal branches to supply face muscles. So this is the starting point and this is the ending point. Starting point is in the pons winding around the 6th nucleus to come through internal acoustic meatus to descend along the middle ear throughout the medial wall and then the posterior wall of the middle ear to exit through stylomastoid foramen. Then it comes and pierces the parotid gland to divides into 5 terminal branches to supply the facial muscles. During its course, it is also associated with a nucleus called as superior salivatory nucleus. Superior salivatory nucleus. So, superior salivatory nucleus fibers also will pass through the same part where 50% of the fibers will enter the pterygopalatine fossa into pterygopalatine ganglion. So, any ganglion in the pterygopalatine fossa is called as pterygopalatine ganglia. So, from these the postganglionic fibers will supply lacrimal gland, nasal glands, palatine and minor salivary glands. Minor salivary glands. And what is this nerve name which is supplying towards the pterygopalatine ganglion is called as greater petrosal nerve. So, superior salivatory nucleus fibers will deviate as greater petrosal nerve to supply these glands through pterygopalatine ganglion. Whereas the remaining fibers will come down and goes through a tympanic membrane as a cauda tympani. So, this nerve is called as cauda tympani. And this cauda tympani fibers will go and ends in submandibular ganglion. Submandibular ganglion. From the submandibular ganglion, it will be supplying to submandibular gland and also sublingual gland. So, look at the red color fibers which are coming from superior salivatory nucleus. Some fibers deviating as greater petrosal now to supply these glands. The remaining fibers will be going through cauda tympani to supply submandibular and sublingual glands. So, almost entire glands in the head and neck region is supplied by this seventh nerve through superior salivatory nucleus except parotid. Here it goes through the parotid, but it is not supplying the parotid. Please remember that one. And cauda tympani has another section called as cauda tympani also carries anterior two-third tongue taste. So this anterior two-third taste also will be carried through the cauda tympani. Right. In between this greater petrosal nerve and the cauda tympani nerve, one more branch will be present, and that is called as nerve to stapedius. What is the function of stapedius is it protects the internal ear from loud sounds. But if that is damaged, then the stapedius will not protect the internal ear from loud sounds. So even if you speak with a small sounds, it appears as a big sounds, or if you listen as a big sound, that's called as a hyperacusis. That is the increased sensitivity of sound. So there should be now to stapedius is damaged. That's why there is a complaint of increased sensitivity or hyperacusis. And there is a loss of anterior two-third sensation. Anterior two-third of the taste is also lost. That means cauda tympani is lost. So somewhere the damage is present here. But the question is asking which foramen, which is nothing but stylomastoid. So relatively the answer is stylomastoid foramen. But exactly if you see the uh, uh, the lesion is present just above the above to now to stapedius, but not the stylomastoid foramen. Just going back to the question again. So anterior two-third of the tongue, there is a loss of taste sensation. There is a right side facial paralysis, and there should be hyperacusis. So hyperacusis when it occurs when there is a paralysis of stapedius. So when there is a paralysis of stapedius, so the lesion should be above the branch of stapedius. Then only we can say okay, this must be lesion. But here there is no other option to go with the facial nerve. The facial nerve is associated only with the stylomastoid foramen. So stylomastoid foramen will be the answer that leads to the lesion of facial nerve. The facial nerve will be leads to the lesions of this. But exactly to say the lesion is a stylomastoid foramen. Look at the image again. Is the lesion is exactly a stylomastoid foramen? No. If the lesion is at stylomastoid foramen somewhere here, there will be no loss of because there will be cardia tympani is intact. If there is a lesion here, cardia tympani is intact, so there is no loss of anterior two-third taste, and there is no loss of stapedius, that is hyperacusis. But as this, there should be the lesion will be somewhere here. But the relative answer is nearby answer is stylomastoid foramen, so we had given answer is stylomastoid foramen. And one more syndrome related with that of facial nerve is called as the crocodile tear syndrome. What is crocodile tear syndrome is whenever there is a damage of chorda tympani fibers, whenever there is a damage of chorda tympani fibers, the regenerating fibers will be coming down all the way like this. The regenerating fibers has to be there. But accidentally, if the fibers are going through it, and it may supply for lacrimal. So, if chorda tympani nerve is damaged, this is a lesion. The regenerating fibers, parasympathetic fibers, accidentally innervates greater petrosal nerve. So, it accidentally innervating the greater petrosal nerve and then supplies the lacrimal gland. So, whenever it's supplying the lacrimal gland, then whenever you are eating, actually submandibular and sublingual has to stimulate, but instead lacrimal gland is stimulating, that leads to tears during eating, and that syndrome is called as crocodile tear syndrome. Crocodile tear syndrome. And there are certain LMN lesions and UMN lesions. What is the difference between LMN and UMN lesions is, in case of lower motor neuron injury, ipsilateral face paralysis will be present. Both upper half of the face and lower half of the face. For example, if right side facial nerve is injured, then right side face paralysis will be, right upper face will get paralyzed, right lower face also will get paralyzed. For example, this is the right side of the facial nerve. If it is get injured at the level of stylomastoid foramen, right upper face will be paralyzed, right lower face also will get paralyzed. But in case of upper motor neuron lesion, it is different. The effect is contralateral lower face paralysis. Only the lower face paralysis will be present. For example, if there is a lesion of right side upper motor neuron lesion, right upper motor neuron lesion for the facial nerve, if it is present on the right side, then contralateral is left, lower half means this one. So left lower part will get paralyzed. Only this area of the muscles will get paralyzed, but not the upper and lower halves. Only the lower half contralateral. So the difference between the lower motor neuron and upper motor neuron is, lower motor neuron is ipsilateral, and upper motor neuron lesions are contralateral. And in case of lower motor neuron lesion, upper half and lower half will get paralyzed, but in case of upper motor neuron lesion, only the lower half will get paralyzed. So lower motor neuron lesion is ipsilateral face paralysis, both upper half and lower half. But upper motor neuron will lead to contralateral lower half paralysis of the face. Is the image that is describing that of upper motor neuron lesions, where this is the cortex of right side, this is the cortex of left side, and this is right upper facial nucleus, this is right lower facial nucleus, this is left upper facial nucleus, and this is left lower facial nucleus. And right upper face will control, right upper facial will control right upper face, and right lower face will control right lower face. Same for here also. Left lower will control left lower of the face. But in case of upper motor neuron lesions, for example, left cortex will come to right upper, left cortex will also receive from right lower, and right facial also receive from these fibers. Okay. So let's imagine 1, 2, 3 are the fibers I am giving. So one is going to right, 1, 2, 3 originating from the left cortex. One is going to right facial, right upper facial. 2 is going to right lower facial, and 3 is going to the left upper facial. If this is damaged, that is called as a UMN lesion. Next, one is damaged. When one is damaged, this right upper facial should not work, but it is still innervated by this nerve, so it becomes functional. If two is damaged here due to upper motor neuron lesions, right lower face should not function, and it is not innervated by any other nerves. And if it is three is damaged, then this should not be functional, but this left upper should not functional facial nucleus, but it is receiving the fibers from contralateral side, so it is still functional. So in case of 1, 2, 3 fibers lesion, the effect is present only on right lower facial, and right lower facial, if it is damaged, then lower face will get paralyzed. So UMN lesion, whenever is present on the left side, what is the effect is right lower face will get paralyzed. No one will ask about this entire concept, but you have to remember only this one, that contralateral lower half face paralysis. Lower half face paralysis will be present in case of upper motor neuron lesion. But in case of lower motor neuron lesion, both upper half and lower half, but ipsilateral present. So going back to the facial nerve part. So here the image is showing that where is the lesion is at the stylomastoid foramen, because the facial nerve comes out through which foramen is stylomastoid foramen.